Welcome everyone. Welcome again to Neurolactics webinar. Today we'll be talking about non-invasive brain stimulation for severely brain-injured patients, and we're going to try to answer the questions with: are we ready for clinical use? And I'm very happy to welcome our guest speaker today. We have with us Dr. Aurore Thibaut, is co-director at the Coma Science Research Group and research associate at the FNRS. So hi, Aurore. Thank you for joining us today.
Thank you so much for the invitation.
Thank you. I will do a really quick introduction. As a physical therapist by training, Dr. Thibaut is interested in developing novel neurorehabilitation strategies for patients with both mild and severe brain injuries. Our research mainly focuses on non-invasive brain stimulation in post-coma patients to improve brain plasticity, facilitate their recovery. And she published more than 100 papers and is leading several multi-center clinical trials within the same topic. She's also working with neuroimaging and electrophysiology to provide objective information regarding plasticity and link it to these therapeutic approaches like non-invasive brain stimulation. And recently she started also to study the concussion and the importance of sleep and motor learning impairments in these conditions. So welcome, Aurore. Thank you for joining us today. Over to you.
Thank you so much, Rafael, for the very nice introduction. So yes, thank you so much for the kind introduction. And as you were saying, so I'm a physical therapist by training. I did my PhD in neuroscience at the Coma Science Group. And so the Coma Science Group that was first funded by Stephen Lorais, a very famous neurologist. And at first, when he started it, the aim was really to improve the diagnosis of patients with disorder of consciousness. But for the past years, with my colleague, Dr. Gosried, with whom I am co-directing the Coma Science Group, we try to now better investigate therapeutic options for patients with disorder of consciousness. She mainly works with pharmacological approaches, and I am working with non-invasive brain stimulation, which is the topic of interest of today's presentation. And so I just wanted also to mention that I first met the people from Neuroelectrics, so Giulio Ruffini, and also people from StarLab, Aurelia Soria-Frisch and Eleni Kurpi, because they got a very prestigious European grant, the Project Luminous. And when I think it was back in 2016, and at that moment there were just a few randomized controlled trials that were published on non-invasive brain stimulation in patients with severe brain injury, patients with disorder of consciousness. And now, like the past 5-10 years, the field really increased, grow dramatically, and I'm convinced this is thanks to people like Giulio, Aurélie, and everyone at Neuroelectrics and StarLab that really are very motivated and brilliant people that really make huge advancements to the field. So I will first, because I think that maybe some of you are not familiar with the thematic of disorder of consciousness, so I will first begin by giving an overview of what is a disorder of consciousness, and I will guide you through the different stages, the different states that can occur after a coma, because we always hear about coma, but actually coma is one of the entities of the disorder of consciousness spectrum. So here, all those patients, they had a severe brain injury due to car accident, hemorrhagic stroke, or cardiac arrest. And so they entered into a period of coma. So what is a coma? It's when the patients, they cannot be aroused. They're not arousable, even following auditory stimulation or nociceptive stimulation. They never open the eyes, and they're not conscious of themselves nor on the environment. And this state lasts usually a few hours, a few days, or sometimes a few weeks due to pharmacological artificial coma. But those patients will, for some of them, either unfortunately die, or they might at least regain eyes opening. And this is what we call the unresponsive wakefulness syndrome, or we also call it vegetative state. We prefer now unresponsive because this is what we observe at the bedside. And sometimes vegetative gives the wrong impression that this is linked to vegetable, even though it's because of the vegetative functions. But so trying to really circumvent this negative aspect, we propose now the term unresponsive wakefulness syndrome instead of vegetative state. So those patients, they can open their eyes, but still they are not conscious of themselves nor on the environment. So if you ask them to move their hand or move their feet, they will not do it. Then some patients will regain some slight sign of consciousness. This is what we call the minimally conscious state minus. And we also have the minimally conscious state plus. And those patients in minimally conscious state minus, they can, for instance, have visual pursuit. And when the patients regain some language-related abilities, such as response to simple command like move your hand, move your feet, or close your eyes, then those are called as minimally conscious state plus. And this is important because this is response to command is the first step through establishing a communication code. And this is what then when the patients regain this ability to functionally communicate, so it can be verbally, but also thanks to a binary code like close your eyes to say yes, move your thumb to say no. Then we say that those patients who are able to communicate, they have emerged from the minimally conscious state. On top of that, we also have what we call, and I'm sure most of you know about the locked-in syndrome. So those patients who are fully paralyzed, they cannot speak, and they can only communicate through eyes movements, like looking up and down, due to a lesion in the brainstem, but they are fully conscious. And sometimes these patients, they can be misdiagnosed as being unresponsive, especially in the following days following their brain injury. So it's still important to take that into account. And sometimes also in our studies, those patients are fully paralyzed, but fully conscious. We sometimes work with them, collaborate with them as a cohort of, as a control group to test, for instance, BCI systems. And importantly, we have not a really new state, but this state gained attention recently, which is what we call MCS stars of minimally conscious state star, or CMD for cognitive motor dissociation, or covert awareness. Those are three terms that basically mean the same thing. But the idea here is that the patients at the bedside, we cannot detect sign of consciousness at the bedside. They can't express that they might be conscious, but when we bypass the motor pathway, then we place those patients in an MRI scanner, or we put an EEG cap on their head, and we ask them to, for instance, imagine playing tennis, imagine walking in your house. Then we can notice that they actually activate the right brain regions, meaning that they are able to answer command when we assess them through MRI and EEG. And so this is what we call covert awareness or cognitive motor dissociation. And this understanding has really led us to a reorganization of how these patients were diagnosed from a two-dimensional state to a three-dimensional approach, incorporating those fMRI and EEG assessments. And this is what you can see here. So those patients who are unresponsive at the bedside, but they can correctly activate their brain regions based on the mental imagery task that the researcher is asking, are called patients with cognitive motor dissociation, covert awareness, or MCS star. And this is a really important aspect that I would like to insist on. So this is another slide just explaining the same thing, but showing again the difference between what we can observe at the bedside and what we can what are those patients actually able to do when we bypass this motor system. So here, this is a schema showing that patient in coma, there is no arousal, no awareness. Then patient in unresponsive wakefulness syndrome or vegetative state, they recovered eyes opening, but still no purposeful behaviors, no signs of consciousness observed at the bedside. And then we have this minimally conscious state minus and plus showing minimal but consistent signs of consciousness. And on the bottom line, you see that those patients, some of them both in coma, unresponsive, or patient in minimally conscious state, when we put them in a fMRI scanner or with an EEG, they can actually perform correctly the mental imagery task that we ask them to do. So again, cognitive motor dissociation. And this is also what we recently highlighted in this huge study that took more than 15 years to complete. And this study involved 6 centers through Europe and the USA. And as at the University of Liège, we were very lucky to take part to this big project that was really published last month, so very fresh. And so here, the idea was to look at patients who had clinical assessment with the scale that we use, the CRSR, so it's the Coma Recovery Scale Revised. They had behavioral assessments, and then they also had fMRI and or an EEG with this mental imagery task. So basically, we asked them to either imagine playing tennis, imagine walking in your house, or imagine moving your closing and opening your hand, or moving your foot. So those were the tasks. And then we noticed that out of these 353 patients that were assessed with both the behavioral and the neuroimaging, 68% could not answer to command, and 32 could behaviorally answer to command. So meaning that when we asked them to move the hand behaviorally, we could see that they were able to answer command. And what is interesting here is that out of these 241 patients, so the 68% that could not answer command, actually 1 out of 4, so 25% of them presented this cognitive motor dissociation, meaning that they could perform the task in the MRI or with the EEG. And interestingly as well is that patients with a traumatic brain injury etiology tended to have to be in a cognitive motor dissociation more often compared to other etiologies. It was also linked to a younger age and a longer time since injury. Another important point here is that when the patient had both fMRI and EEG, the proportion of them being with cognitive motor dissociation was higher, meaning that if you combine techniques but also repeat assessments, you have better chances to detect this cognitive motor dissociation. And the last thing I would like to highlight in this slide is the fact that actually for patients who did answer to commands at the behavioral level, only 38% of them could perform correctly the task in the scanner, meaning that we might have kind of high rates of false negative, meaning also that this 25% of cognitive motor dissociation might actually be underestimated, and more patients than that are actually much more conscious than what we can actually observe at the bedside. All right, so that was for the introduction of different states of patients with disorder of consciousness, but now let's move to the therapeutic options for those patients. So by definition, this is the patients you can see on the figure on the left. So by definition, those patients, they cannot communicate. And this is mainly the biggest problem to have access to rehabilitation strategies. We are really limited because we cannot communicate with them. And in addition, they may suffer from severe disabilities, like motor, severe spasticity, motor dysfunction, aphasia, and so on, which limit even more their abilities to interact with their environment and to have access to conventional rehabilitation strategies. Another issue, especially in the chronic settings, because those patients, they can stay in this state for months or even years. Another issue is that some of those patients might seem hopeless, and the therapeutic options might be just judged useless. But fortunately, in the recent years, we have seen that several therapeutic options could actually be effective even in chronic patients, and that some patients, even years after the injury, can still improve. So it's really important to continue our effort to try to treat those patients even years after the injury. And recently, as part of the Coma Curie campaign that was initiated by the Neurocritical Care Society, we had the Coma Science Work Group, and that was led by Brian Edlow at Harvard University. And so we conducted a gap analysis on therapies for patients with disorder of consciousness. And based on the current literature, we highlighted specific gaps. So we reviewed the literature and we categorized those therapies into 5 types, which were the pharmacological, the electromagnetic, so TDCS, TMS, which interests us today, mechanical as well, such as ultrasound therapy, and then sensory, such as music, for instance, and then finally regenerative, like stem cell therapy. And very interestingly, we could see that the most studied intervention were actually non-invasive brain stimulation like TDCS and or TMS. And at the time when we conducted this review, there were 10 ongoing clinical trials that were registered on clinicaltrial.gov. So still highlighting that the field is really moving forward and growing. And based on that review of the literature, we developed specific gaps, saying that indeed there is a growing evidence showing that some patients may improve even years after the injuries, that some treatment might be effective, but still we need to really develop precision medicines as well as multicentric trials, really to making sure that we have enough statistical power to prove the efficacy of a treatment or not. And also, we really need to better understand the mechanisms of actions of these treatment options, but also the mechanisms of how the brain can recover, how patients with disorder of consciousness can regain consciousness. As I just said, we need to better understand the mechanisms of actions, and to date, the primary hypothesis that really explains the recovery of consciousness in patients with disorder of consciousness is the mesocircuit model that was first developed by Nicolas Schiff from Cornell University back in 2010. So just very briefly, what we need to understand is in this model is that due to severe brain injury, we can have an impairment of the striatum that can be direct because of the injury, or indirect due to lack of output from the cortex, and preferably the prefrontal cortex. And this inhibition, this lesion of the striatum will inhibit the globus pallidus interna, which normally inhibits the thalamus. And so we have an increase of inhibition of the central thalamus, which in turn additionally increase the thalamocortical connectivity, which might already be impaired in the context of disorder of consciousness. So we have kind of a double inhibition of the central thalamus and the thalamocortical connectivity because of a lack of inhibition of the globus pallidus interna due to a lesion of the striatum. And this was developed following the amazing discovery that zolpidem, which is usually a sedative drug that people take to fall asleep. So this GABAergic agent we think that it might work on the globus pallidus interna, reducing its activity, thus reducing the inhibition of the thalamus. And very interestingly, we noticed that most of the drugs, but also the non-invasive brain stimulation approaches that have been tested in the context of disorder of consciousness, most of them, or if not all of them, work in specific regions that are part of this mesocircuit model. And when we talk about brain stimulation, which is what interests us today, we can kind of categorizing them based on, in different ways. And one way to categorize them is based on how they act. So some of them might work in a kind of how we call a top-down manner. So for instance, a transcranial electrical stimulation, transcranial magnetic stimulation, where we target specific cortical areas to promote, to increase the excitability. We have also bottom-up stimulation, such as the vagus nerve stimulation. So here we try to reach the brainstem that will then reach the thalamus, increasing this thalamocortical connectivity. And finally, we also have central stimulation that can directly act over central brain region, and the region that interests us the most in terms of disorder of consciousness is the central thalamus. So those also deep brain stimulation or low intensity focused ultrasound have been tested to really try to stimulate the central thalamus. And we will go over those different approaches during the rest of the talk. And so we will start with top-down approaches, and the one approach that have been well tested in the past 20 years, and I think it is the most studied intervention in patients with disorder of consciousness, is transcranial direct brain stimulation. So here at the lab, we have conducted several randomized controlled trials where we tested different montages targeting different brain regions. So the first one was targeting the prefrontal cortex, because we saw in the mesocircuit that there is direct connection from the frontal cortex to the striatum, which could then increase indirectly the thalamocortical connectivity, also increase some executive function. And so we tested the use and the efficacy of prefrontal stimulation with kind of consistent clinical improvements. The clinical improvements were mainly observed in patients in minimally conscious state and not in those who were unresponsive. We also tried to target the precuneus and we placed the anode over the posterior parietal cortex, but we had kind of limited results. And the reason why is because the precuneus is also a very important hub for internal consciousness processes. In the context of cognitive motor dissociation, because really motor output is so important when we try to interact with the patients with disorder of consciousness. With this idea in mind, we tried to stimulate the motor cortex, but we did not find any improvements targeting the motor cortex. And finally, as part of the Luminous project that we conducted with Neuroelectrics, we tried a very nice multi-channel montage targeting the entire frontoparietal network, which is underlying the consciousness of our environment. So basically trying to help those patients to interact with the environment. And so with this multi-channel device, we targeted this frontoparietal cortex. So it was a single stimulation. So at the behavioral level, we could not find any significant improvements, but we did find some improvements in brain activity after this single stimulation. So this could still be useful if maybe we apply with the protocol with more stimulation sessions. And so based on all those studies, our conclusion regarding TDCS in DOC in patients with disorder of consciousness is that targeting the prefrontal cortex might be the best target so far that we have studied. However, we must stress that the effects are still moderate. So it's not like the patient will really, speak again or walk again. There is some improvement at the behavioral level, but those improvements are still moderate. And you will really need to have individualized protocol. So we know that those patients, they have extensive brain lesions that might influence how the current is distributed. We know that those patients, they have fluctuation of vigilance that might also affect how the stimulation is efficient. So we really need to optimize and have more individualized protocol. And here it is just a small video of patients that responded to the stimulation. So I can just show you what the patients look like and what kind of benefits we should expect to observe. And so we had a spoon in his hand and we asked him, can you show us how to use the spoon? So he was supposed to then bring the spoon to his mouth and he really couldn't do it. We see, it was very difficult for him to do it. And then we did the stimulation and this is how he did right after. And the father is saying, oh, wow, you were very fast at really bringing the spoon to your mouth. So he was really more able to really control his movements. And so he was able to make the right move. So as you see, it's not really dramatic improvement, but still, and especially for patients who are in this state for many, many years, it can be still very useful to have those kind of behavioral improvements. And another objective that was highlighted in the gap analysis paper I presented in the introduction is really the need to do multi-center trial. And why is it so important in the field of disorder of consciousness to do multi-center trials is because, fortunately, this condition is rare, meaning that you don't have many patients in this condition that then you can enroll in your trial, right? So we really need to combine forces to get clinical trials that are conducted in sample size that are big enough, or it takes many, many years to conduct. And so as part of the DOCMA project, as well as the IBIA DOCSIC panel, we conducted this first multi-center trial through Europe, and we assessed the effect of TDCS applied during 4 weeks while the patients were in a rehabilitation center. So it was done on top of a conventional rehabilitation program. And the idea was to see whether combining TDCS with the rehabilitation could really enhance the efficacy of the rehabilitation. As we had a bigger sample size, we could also do subgroup analysis, trying to find out whether patients with different etiologies might respond better, as well as if there was any difference between patients who were unresponsive or minimally conscious. And we assessed the effect every week, but as well as at 3 months follow-up to see if the effect could last over time. So we enrolled 64 patients. Half of them were in minimally conscious state, 23 from traumatic etiologies. And so the group was divided in two. Half of the group received active stimulation, the other group received sham stimulations, and the assessors were completely blinded of the group allocation. We assessed the effect with the Coma recovery scale, so once a week and up to 3 months follow-up. So at the group level, we did not observe any clinical improvement. However, we did subgroup analysis, so we looked only at unresponsive patients, minimally conscious patients, and only at patients with TBI, traumatic brain injury etiologies, and non-traumatic brain injury etiologies. And on the left, you see the improvement, basically, so the difference pre and post on the Coma recovery scale revised for all the groups. And we did not see significant improvement. However, when those patients were reassessed at 3 months, we can see that the group of patients in minimally conscious state here increased by 2 points on the scale, and the same thing was observed for patients in traumatic brain injury, meaning that for this subgroup of patients, minimally conscious state and TBI, TDCS can really increase the efficacy of rehabilitation in those patients, so in the subacute stage of a disorder of consciousness. Another really important aspect is, of course, the clinical translation of TDCS, which is especially important for a patient with disorder of consciousness, because it's very complicated, of course, for those patients to be transported to a clinical or research facility. And so here we conducted a home-based study that was led by my colleague Géraldine Martens, that you can see here. And so basically, we were using a very user-friendly device. The parameters were fixed in that device. And so it was the family and the caregivers or the relatives that were applying the stimulation while the patient was either at home or in a nursing home. So we would train them, obviously, and then also the device would record if the stimulation were applied correctly as asked. And so it was, again, 4 weeks of stimulation, so 20 sessions. And the patients received first 4 weeks of active or sham, then 8 weeks of washout, and then again 4 weeks of sham, so it was a crossover design. We enrolled 27 patients in minimally conscious states. And very nicely, we saw that the adherence was very good, meaning that the stimulations were correctly applied. But again, at the group level, no clinical improvement. However, we noticed that 5 of those patients did not receive the number of stimulation that they were supposed to receive. They received like 5 stimulation, and then we don't know why, but the clinical staff stopped doing that. So basically, when we removed those 5 patients who did not receive at least 80% of the stimulation session, we did find an improvement. And this is what you can see here on the graph. Again, those patients in the active group compared to the sham group increased by 2 points on the Coma recovery scale revised. But when we reassessed them at 8 weeks follow-up, the improvement tended to disappear. And this was extremely impressive because those patients, they were in this state for many, many years, again, showing that even years after the injury, you can still see improvements in the recovery of consciousness. And this is just one case I would like to show you because I really think that it's a very interesting case, especially in the context of the cognitive motor dissociation that I presented at the beginning of the presentation. So here, it was a patient who came to our research facility for like a full assessment, behavioral assessment. We also did fMRI, a DTI. We did the mental imagery task in the fMRI, asking the patients to play tennis or imaging moving in her house. And this patient was diagnosed for 4 years as being unresponsive, so not conscious. And we did 7 behavioral evaluations. Out of these 7 behavioral evaluation, we only noticed once a localization to a painful stimuli, which is a sign of consciousness, but minimally conscious state minus. And we did apply the stimulation, the TDCS, over the prefrontal cortex, and we found, and the patient could consistently respond to command after the stimulation session. So we were very surprised, and we can also doubt whether we could really see this was true, that the patient could respond to command after the stimulation. But then we looked at all her results, all her neuroimaging results, and on this graph, you can see on this figure, you can see on the left what we see in the typical unresponsive patients, on the right of a healthy control, and in the middle, you can see the result of the patients. So the first line is the residual brain metabolism, which is quite preserved in the patients. The second line is the DTI, so the white matter, which is also quite preserved. And finally, the patients could correctly imagine playing tennis while she was in the fMRI. So we say, okay, this patient suffers from cognitive motor dissociation, and maybe TDCS might have facilitated the motor execution of the command that we asked for. So in the context of this cognitive motor dissociation, TDCS might be helpful. And the nice side I would like to present on TDCS is a very ambitious protocol that we started with, again, Neuroelectrics and Star Lab as part of the Luminous project. And so they built a very sophisticated device to answer another gap that we have in our field, which is how to optimize and individualize those treatments. And so here they developed a closed loop system that measures online the patient's spectral entropy, and we use the spectral entropy as a proxy for measuring the patient's vigilance. We know that patients with disorder of consciousness, they have very high fluctuation of vigilance, and so our rationale is that when you apply the stimulation when the vigilance is low, it might be less efficient. When you apply when the vigilance is high, the stimulation might be more effective. And so this is what we do. We put a cap that both record and can also trigger the stimulation automatically based on the patient's individual fluctuation of vigilance or spectral entropy. And we just completed the pilot study, enrolling 16 patients, and we are in the process of analyzing the data. So hopefully next time I will be able to present some exciting results. So we saw a lot of work that has been done with TDCS, and another interesting approach, top-down approach, is repetitive transcranial magnetic stimulation. And so here it has been widely tested in many neurological conditions. And for patients with disorder of consciousness, several targets have been tested, the motor cortex with no behavioral improvement. There are open label studies that show that targeting the prefrontal cortex as TDCS could be efficient. And a nice open label study also targeted the angular gyrus, showing important improvement in patients in minimally conscious states, but not in unresponsive patients. And to know whether stimulating what would be the best area to target will be either the angular gyrus or the prefrontal cortex, or if one might work better in some patients than in other, we have this nice randomized control trial that is kind of an individualized randomized control trial that is led by Marie Vitello and Olivia Gosris. And so here they test both angular gyrus and prefrontal stimulation in all patients, and based on the best response, then the patient will go to a 4-week protocol applying the 20 sessions of TDCS. So they are ambitious as they plan to enroll 90 patients. And so the project has started. So again, we really hope to have some interesting results to present in the years to come. All right, so this was for top-down approaches. And now let's move to bottom-up approaches. So one way to stimulate the brain in a bottom-up manner is through the stimulation of the vagus nerve. And so there was this first study published in 2017. It was a case report of a patient who received invasive vagus nerve stimulator. So it was implanted surgically. And the patient was in non-responsive wakefulness syndrome. And after 1 month of stimulation, the patient regained some sign of consciousness. So it was very impressive to see that these patients could really regain a sense of consciousness years after the injury. So, but this was a case report, and there is no randomized control trial that are available so far. On top of that, this population of patients is very fragile, and so doing the surgery is not always easy. So that's why we always try to find alternative, non-invasive way to stimulate the patient's brain. And so we can also use non-invasive vagus nerve stimulation through the auricular branch of the vagus nerve. And there are a few case series and open label studies, as well as recent randomized control trials that have been performed in patients with prolonged disorder of consciousness. And they have shown that it could be efficient in improving the recovery of those patients. And this was also a study looking at fMRI showing that following the application of vagus nerve stimulation, there was an increase in brain activity in key regions for the recovery of consciousness. And so why do we think that applying stimulating the vagus nerve could increase the recovery of patients with disorder of consciousness? So here I told you we take the advantage of the anatomy of the vagus nerve having an auricular branch that you can see in green on the picture of the ear here. And so by stimulating the auricular branch of the vagus nerve, it could then activate the tractus solitarius in the brainstem, which then may activate the locus coeruleus and the raphe nuclei. And those two nuclei are part of the ascending reticular activating system. So basically directly potentially increasing wakefulness, as well as then stimulating this thalamocortical connectivity with the direct link with the thalamus, but also these two nuclei will stimulate the serotonergic and noradrenergic pathways, which are two important excitatory neurotransmitters, which may also act on the patient's recovery of consciousness. And the big advantage of vagus nerve stimulation is that it's very, very easy to apply. So here you see that the kind of ear plug that we place in the patient's ear. So it's very easy. And then that's basically it. And so here you see a patient that has an EEG, high density EEG on the head. And the patient actually is in the intensive care setting. It's only a few days after the injury, and because of its so easy, simple to apply, even in very challenging settings such as the intensive care unit, we can use these stimulation approaches. And this is what we try to do. And before, all our studies were conducted in chronic patients while they were in rehabilitation or in nursing homes or even at home. But obviously we think that it would be more important to try to act earlier in the acute phase, really to fasten or promote the recovery of those patients as soon as possible. And so here is also the work of Marie Vitello. So we are conducting a double-blind randomized control trial in patients in the acute setting, so in the intensive care unit or the neurology ward. And we apply the stimulation for 5 days, and we assess the effect at the behavioral level, but also we record EEG before and after. And so we do 5 days of stimulation for 45 minutes at a maximum of 3 milliampere. And the patients are divided again in 2 groups, the active and the sham group as a control condition. And actually, there is only 2 patients to go, so hopefully next month the study will be completed. But we planned initially interim analysis because it was the first time that we were conducting a study in the acute setting. So we planned interim analysis when half of the sample was completed to assess safety, but also feasibility, and potentially reevaluate the sample size. Very nicely, we didn't find any serious adverse event. And in terms of feasibility, only 2 patients dropped out. So the study was feasible, even though challenging for Marie, but feasible. And in terms of the evaluation of the sample size, so our primary outcome was the improvements on the Coma scale at baseline compared to the last day of stimulation, so after 5 days of stimulation. And here we saw that you have a significant improvement of 2.5 points on the Coma scale, so a significant improvement after 5 days of stimulation. And we recalculate, so we redid the power calculation, and we decided to stick with our initial plan to recruit 44 patients. So as I was just saying, we just have 2 patients to go to complete the sample. And we also have obviously to look at the EEG and the ECG data that we are collecting as well. And this is just also a video of a patient who kind of well responded to the stimulation. So here it was a patient who was 18 years old patient after a severe TBI. The patient was only responding to command at the first day. And here, this is what he could do after 5 days of stimulation. And so after 5 days of stimulation, the patients could functionally use object as well as functionally communicate, meaning that he emerged from the minimally conscious state. So of course, not all patients improved that well. And the patient was in the acute state, so we cannot exclude natural evolution, but still extremely encouraging results. So before I conclude, I would just like to present you 2 slides on central approaches that I think there are still a lot to do, and they might be extremely useful to promote the recovery of those patients. The first one is the very famous deep brain stimulation. It's widely used for Parkinson's disease, but here we also, we didn't do it, but it was a first study by Nicolas Schiff from Cornell University, also in collaboration with Joe Giacchino from Harvard, and they implanted a stimulator in the intralaminar nuclei of the thalamus because of the connection also with the frontal cortex and the cortex in general. And so here, the patient, it was a case report, the patient was in minimally conscious state for many years. And when the stimulation was turned on, then the patients regain some important, significant sign of consciousness, such as he was able to say words in an intelligible way. He also had sustained attention, and he could also use functionally some objects, so he emerged from the minimally conscious state. Later, there was other open-label studies that were conducted, but with some mixed results. Again, as I was saying before, for vagus nerve stimulation, those patients are fragile. And so when you do such heavy surgery, they can suffer from infection and complications. So people are really cautious doing those very invasive surgery. And of course, it's very complicated to conduct randomized control trial. But still, I think it's worth mentioning. Then we also have a very, very elegant technique that kind of combine both worlds, being safe as non-invasive brain stimulation, but going deep as deep brain stimulation. And this is using low intensity focused ultrasound therapy. This is really a topic that emerged thanks to the great work of Martin Montiel from UCLA. And he already conducted a few case reports and case series using this technique. That is, the effects are not yet entirely understood, but it might be more like a mechanical way to stimulate the neurons membrane. And here it's a bit complicated to put in place because you need the patient's MRI to make sure that you place the probe in the appropriate way to really target here again the central thalamus. But he had a very interesting result when applied in acute patients as well as in chronic patients, because here it was a case series and 2 of the 3 patients significantly improved, even if those patients were in this state for more than 1 year after the injury. So very encouraging results. And I know that they are conducting a randomized control trial, so hopefully we will get those results very soon. But I think it's also a very promising technique. All right, so to conclude, so I think that I'm not sure whether I answered the first question, which was, are we ready for a clinical use of TDC, of non-invasive brain stimulation? So regarding top-down approaches, we can say that TDCS is safe for patients with disorder of consciousness. And so far, it seems that targeting the prefrontal area seems to be the best area to target. Patients with traumatic brain injury and in minimally conscious states might respond better to the treatment. And we need to have repeated stimulation to increase the duration and the number of responders. So for TDCS, we can only recommend as it is safe to use it in combination to rehabilitation strategies. But we have a lot of work to do to improve, to optimize its efficacy. We should try other techniques such as TMS, but also we have a lot to do with alternating current stimulation, theta burst stimulation, and so on. For bottom-up and central approaches, we saw, of course, DBS is promising, but it's extremely invasive and there is no clinical trial. But we have other approaches that are being tested at the moment, such as ultrasound or the transauricular vagus nerve stimulation that hopefully have a very promising finding that will come up soon. And so what should we do next to enhance the effect of the stimulation? So we just went over different top-down and bottom-up approaches that could promote the recovery of sign of consciousness. But despite that, we saw that there is some group-level improvement. There are still, as I was saying, a lot of patients that, I mean, the effects are moderate, and there are a lot of patients that do not respond to the type of stimulation. And so, for instance, we could optimize the effect of stimulation by using this closed-loop system that I presented earlier, really triggering the stimulation based on the patient's level of arousal, hopefully enhancing the effect of TDCS. Importantly, patients with severe brain lesions, they have dramatic structural brain lesion that can obviously affect the way the current is distributed. And there are advanced methods using individualized brain lesion from structural MRI that can compute the current distribution based on the different TDCS montages. And there have been some preliminary analysis that show that this individualized brain montage, TDCS montage, based on the patient's brain lesion could actually increase induce a stronger electrical field in the target brain regions, so it could be potentially theoretically at least more efficient. And this was again done in collaboration with Neuroelectric and Starlab. And I really truly think that there is not one size-fits-all technique for patients with disorder of consciousness. It's a very heterogeneous population, so we need to have more individualized approaches, and also having this combination of therapies. Why not combining a top-down and bottom-up approach to stimulate the brain in a more holistic way, like combining TDCS with TAVNS, for instance. And going back to the first slide showing the importance of this cognitive motor dissociation, then we always focus on consciousness recovery, which we all agree it's extremely important, but we should maybe also target more the motor pathway, combining TDCS with physical therapy, trying to reduce motor disorders such as spasticity. So maybe try to focus a bit more on the motor system as well. So I think I'm done here. So thank you for your attention. Thank you again for the invitation. And of course, I would like to warmly thank the entire team at the Giga Consciousness, at the Coma Science Group, and also all our amazing collaborators worldwide, without whom it will be impossible to conduct the work we do with those patients. And of course, thank you to the patients and their families for their continuous support. Thank you.
Thank you, Aurore, very much. Thank you for the presentation, and thank you for this encouraging results, preliminary results, and also some very good results that you were presenting. So we have time for some questions. So if anyone wants to ask something, you can use the Q&A tool you have in the Zoom bar, and we'll try to answer the questions. And following with this, Aurore, I have very general questions regarding the mechanism that determine the effectiveness of non-invasive brain stimulation, but also other techniques that you are using. And you were showing actually in MCA's patients, especially, the effect when you're stimulating prefrontal cortex, dorsolateral prefrontal cortex, but actually not in the regions that are like strongly associated with the consciousness related functions like precuneus or parietal region. Any explanation regarding why frontal region and not actually the classical consciousness related targets?
Right. So I think that for the prefrontal cortex, the idea here is, this is again a picture of the mesocircuit, it has direct connection with the striatum, which is an important part of the mesocircuit model of the mesocircuit. And so by directly acting over the frontal area, but first you might act over the prefrontal cortex, but also stimulate the striatum, thus reducing the inhibitory effect of the globus pallidus interna. So having this kind of a double way to promote the brain. So that's the reason why. Another thing that is important to take into account is the protocol that we use to test motor, the precuneus and the frontoparietal. For those two, those were single stimulation sessions that might not have been enough to induce behavioral improvement. For the prefrontal one, we conducted studies where we applied the stimulation for 5 or even 20 sessions. So this obviously might have induced stronger behavioral improvements.
Perfect. Thank you very much. And actually, if you are with this very nice slide presenting that we can use the top-down techniques, bottom-up, and actually central approaches. What is there any algorithm, any classification for patients? Which technique you will use for which patient, and having in mind the heterogeneity of the population?
Yeah, I think that's the question everyone wants to answer. And we hope that with all the ongoing previews and ongoing studies that are conducted, at some point we will have enough data really to put together all of them, trying to see if there is one biomarker that can predict which treatment the patient might receive. But I think we are still a bit far from getting there. But this is really everyone wants to achieve that goal. What we noticed, though, and I did not present that, is that for TDCS at least, it seems that the patients need to have at least a partially preserved brain metabolism, but also gray matter under the stimulated area. So for the prefrontal cortex, if the patient had extensive brain lesion over the prefrontal cortex, the patient could not respond to the stimulation. So that's one very small step toward that. But indeed, I think we will need to combine a lot of data sets from clinical trials, and then using maybe deep learning to really see which biomarker could predict the efficacy of different treatments approaches.
Perfect. Thank you. We have a question from Vitol. It's regarding another modality of electrical brain stimulation, like TACS and TRNS, random node stimulation, alternating current stimulation, and with combination with TMS, and how this could affect the working memory. And for example, this is very effective in post-stroke rehabilitation when you use TRNS in combination with multifocal transcranial direct current stimulation. If you find this type of modality also useful for disorders of consciousness.
Yes, thank you for the very interesting question. Indeed, I think using TACS to target a specific frequency is also something that we should explore. Actually, there is a study that is ongoing in Montreal, testing the effect of TACS applied at 20 Hz in those patients. So let's see, but indeed, but I think what is maybe a bit complicated that kind of prevent us to conduct such TACS studies, really trying to find out the proper frequency to target. Here you mentioned 6 Hz, but we could also target the beta or even higher frequencies. But if we go too high, we might, miss this entrainment effect. And so maybe we should go for more individualized, based on the patient's peak oscillation. So I think there, in terms of selecting the proper frequency, there is still a lot of open questions, but indeed it is really something that we should do. And as I was just saying, there is a team of Louis Beaumont in Montreal and doing testing 20 Hz TACS at the moment in DOC patients.
Okay, thank you. So in terms, when you are talking about personalization of stimulation, especially for non-invasive brain stimulation, we'll need do optimized stimulation. We'll have to have MRI of these patients actually to do, and especially for patients with lesions and the lesions in different regions, to create the model, what we are doing in neurometrics, create the personalized montage for the specific subjects, and different for every subject and patient.
Indeed, but most of those patients they have a T1 MRI because they have extensive brain lesions. So clinically, they have to go through an MRI. So it's like it's data that we have usually.
That could be used and used in the individualization pipeline. Perfect. And regarding timing, actually, the general question in the neuromodulation field, when to stimulate, it's even more complex with patients you are dealing with, because you even have more complex approach when to stimulate. No, so you will need also you don't have behavioral responses, or we have very minimal behavioral responses from patients. And if you want to use, for example, task or specific task, or stimulate during the task or before the task or after the task, you are missing this behavioral responses and the timing when to stimulate and will be the best moment. So I don't know if EEG could be somehow here helpful to have the information regarding when to stimulate.
Yeah, I think you totally get a lot of issue challenges that we face with disorder of consciousness. But yeah, I think that in terms of when applying the stimulation, I think that of course EEG could help, and this is what we have been testing with this closed loop also approach. But again, then they might have other surrogate markers that we could see, trying also maybe potentially to find ways to improve patients' motivation, because those patients they also suffer from a lack of some kind of apathy. And so actually we noticed that it was a very elegant study that was led by Carol Schnackers in UCLA, and so we tested the efficacy of applying preferred music, and just by making the patient hear his preferred music for a few minutes, it really improved the patient's ability to interact with his or her environment, improve the score on this behavioral scale, just by applying preferred music for a few minutes. Really, so the idea is that it will engage the patient. So why not also trying to not only measure when would be the best time to stimulate the patient, the best moment, but trying to engage the patients to really and then apply the stimulation at that moment.
Okay, thank you very much. Actually, the follow-up question from Alberto we have regarding why spectral entropy is considered meaningful in this kind of studies. So this is related to the talking about vigilant state and somehow timing of the stimulation.
Yes, so actually we used it. I mean, we know it's not ideal, but we used it as a proxy to measure the patient's arousal. We noticed that it was a study published in 2016 by Andrea Piarulli, that we have this fluctuation of vigilance every 70 to 80 minutes in patient in minimally conscious state that might correspond also to a fluctuation in the behavioral responsiveness. And so, and this was based on the spectral entropy. We also know that there is a difference in terms of patient states. So the more you are conscious, the higher the entropy. And so that's why we decided to go for that matrix.
Okay, so you have actually, so this will answer the question regarding timing when. So we are measuring the entropy, and based on the level of the entropy, you start the stimulation when this vigilant state is actually reaching the specific threshold.
Exactly, yes.
Perfect. Thank you very much, Aurore. We are running over our time. Thank you for the great presentation. We don't have more questions right now from the audience, so thank you very much.
No, thank you so much for the invitation. It was really nice participating to the webinar.
Perfect. We're really a pleasure, and we'll invite you for the next updates, especially for the studies that are now ongoing, and hopefully soon we'll have another promising results. And also invite you and all the audience for our next webinars and panels. You can see additional information at our webpage, neuroelectrics.com, and see you next time, and see you during our next webinar. Thank you very much. Goodbye.
Thank you. Bye.
Thank you. Bye.